Hey everyone, Lieutenant Rucker here. Today I'm going to talk to you about anesthesia management for nephrectomy. We're going to cover a basic review of renal anatomy and physiology. We're going to talk about anesthetic implications of renal disease, review epidemiology of nephrectomy, talk about indications for the procedure, and then finally discuss the anesthetic management for nephrectomy, including preoperative assessment, monitoring, positioning considerations, intraoperative and postoperative management. There are normally two kidneys with approximately 1 million nephrons or functional units each. Each kidney is supplied by a single renal artery that branches off of the aorta. This main artery divides into interlobar arteries at the renal pelvis and further divides into arcuate arteries at the junction of the renal medulla and cortex. These arcuate arteries give rise to interlobular arteries, which eventually supply each individual nephron via the afferent arteriole. Renal blood flow then courses through a tuft of capillaries known as glomerulus and exits via a single efferent arteriole. Efferent arterioles give rise to a second peritubular system of capillaries, which are most responsible for reabsorption of components from the renal tubules back into the bloodstream. This second capillary system is drained by renal venules, which ultimately empty into a single renal vein and back into the inferior vena cava. The renal corpuscle consists of the glomerulus and a portion of the renal tubular system known as Bowman's capsule. Filtrate that crosses from the glomerulus into Bowman's capsule then travels through a series of tubular components of the nephron, including in order proximal convoluted tubule, descending loop of Henle, then ascending loop of Henle, thick ascending loop of Henle, distal convoluted tubule, and finally the collecting ducts before emptying out into a single ureter, which carries urine to the urinary bladder for storage before being excreted via a single urethra. Each of these tubular components have a specific function with regards to fluid and electrolyte management. I'm not going to go into detail for this presentation, but these functions are succinctly described in Table 29-1 in Morgan and McHale 5th edition. A few additional things to mention with regards to renal physiology, which may be testable factoids in the future. So renal blood flow accounts for 20 to 25% of cardiac output and is normally autoregulated between mean arterial pressures of 80 and 180 millimeters of mercury. Recall that the kidneys not only regulate body fluid and electrolytes, but are also important organs in the regulation of systemic blood pressure via the renin-angiotensin-aldosterone system, also known as RAS. The kidneys also secrete erythropoietin in response to decreased blood oxygen levels in order to promote red blood cell production in the bone marrow, ultimately increasing oxygen carrying capacity in the blood. And finally, and perhaps most importantly, the kidneys are responsible for the metabolism, filtration, and excretion of many types of wastes from the body, including ammonia, urea, and many pharmacologic metabolites. These next few slides are meant to be a basic review of the pathophysiology of renal failure, focusing specifically on the major anesthetic implications of perioperative care for this patient population. Recall that serum creatinine levels alone may not accurately reflect renal function in a critically ill patient due to altered rates of creatinine production and changes in creatinine's volume and distribution. Therefore, creatinine clearance is considered a superior assessment of overall renal function in this population. Just to review acute kidney injury, the rifle criteria, again, not going to go into detail, you guys know this, but if you need to review, it's on M&M, page 655, figure 30-2. Creatinine clearance can be calculated by the following equation. So you take 140 minus the patient's age, you multiply that number by the lean body weight, and then you divide all of that by 72 times plasma creatinine. You just need to remember to multiply this final number by 0.85 for females. So renal failure and implications with regards to anesthesia, so we'll just talk a little bit about the drugs that we use. IV anesthetics, so propofol and ketamine, there's really no change with regards to renal function. Barbiturates and benzodiazepines have shown increased sensitivity, so there's less protein binding and there's more free drug available. And then opioids, you want to be careful specifically with morphine and meperidine because of their active metabolites and slow filtration and excretion in renal failure. Inhaled anesthetics are reported to be an ideal agent for this population, specifically the volatile agents. Nitrous is okay if blood oxygen levels can tolerate having a lower concentration of oxygen to accommodate the nitrous. And then sevoflurane with fresh gas flows greater than 2 liters related to compound A, and we all know, we've discussed this in class with regards to the studies done on pregnant sheep and then some rats with regards to renal issues, but it really hasn't panned out in the human species. Neuromuscular blocking drugs, so succinylcholine is okay as long as the patient's potassium is within normal limits. If a patient requires dialysis, they may need that prior to receiving succinylcholine or prior to an anesthetic to make a succinylcholine a viable option. Steroidal non-depolarizing neuromuscular blockers, so that includes your rocuronium and vecuronium, show a prolonged duration of action because they are partially cleared by the kidneys. And then the benzyl isoquinolones, so that's atracurium and cisatracurium, are your agents of choice because, as we all know, they're metabolized via Hoffman elimination and partially esterase metabolism, and therefore the kidneys don't play a role in their clearance. As far as anesthetic adjuncts, so anticholinergics can accumulate if you have to repeat the dosing. Talks specifically about atropine and glycopyrrolate. Scopolamine is, you don't see this so much with scopolamine. Histamine antagonists, you want to reduce the dose of medications like ranitidine. And then the phenothiazines like Phenergan, there's really no change. The 5-HT3 receptor antagonists like Zofran, there's no change. And then anticholinesterases, again, you'll see a prolonged duration of action. So it talks about, in Morgan and McHale, it talks about, administer these medications to reverse your neuromuscular blockade. You 9 times out of 10 will not see recurarization in the PACU because of accumulation or prolonged duration of action of your neuromuscular blockers. So there are 3 types of nephrectomy: partial, simple, and radical. Partial nephrectomies, also known as nephron sparing, are indicated for limited benign disease and even isolated cancerous lesions. The goal for this procedure is to retain as much of the normally functioning portion of the kidney as possible. A simple nephrectomy is the removal of the kidney and renal pedicle only. This procedure is indicated for non-functioning or obstructed kidneys, polycystic kidney disease, donor transplant removals, and as surgical treatment of uncontrollable renal hypertension. Radical nephrectomy includes the removal of the kidney, the corresponding adrenal gland, the perinephric fat, and Gerota's fascia, which is a thick elastic connective tissue sheath that encompasses all of these previously mentioned structures around the kidney. This procedure is almost always performed in response to a diagnosis of renal cell carcinoma. So approximately 51,000 nephrectomies are performed in the United States each year and are slightly more common in males, 1.6 to 1 ratio, male to female. Nephrectomy carries a relatively high risk of morbidity at 15%. Some of the possible bad outcomes can include DVTs, pulmonary embolism, atelectasis, renal dysfunction, prolonged ileus, and blood loss requiring transfusion. However, this procedure is associated with quite a low mortality rate of approximately 2%. With regards to preoperative assessment, so because cardiovascular disease risk factors are commonly associated with renal cancer, so you have advanced age, male gender, chronic or end-stage renal disease, and hypertension, it may be prudent to evaluate the patient's cardiac status preoperatively if indicated, and you base that on your patient's presentation and their specific medical history with regards to chest pain or exercise tolerance, etc. Preoperative EKG and chest X-ray may be indicated. Labs could include hematology, chemistry, including calcium, LFTs, a bleeding profile, and of course a urinalysis. Type and cross is necessary related to the significant risk of intraoperative hemorrhage, and a CT or an MRI may be indicated if cancerous lesions invade the inferior vena cava or the right atrium. Hereditary conditions that are also associated with kidney cancer include Birt-Hogg-Dubé and Hippel-Lindau syndromes and may necessitate additional respiratory and laboratory studies. So the Birt-Hogg-Dubé, as you can see there, is associated with pulmonary cysts, which could cause spontaneous pneumothorax, and the Hippel-Lindau syndrome is related to pheochromocytoma and other like paraneoplastic or neuroendocrine tumors. So with regards to monitoring and positioning, monitoring and IV access, standard ASA, Foley catheter, 2 large bore PIVs, and because of the risk of labile blood pressures and blood loss and frequent necessity for blood sampling, you may consider an A-line or even a central venous catheter on these patients. Again, your patient's medical history is going to dictate your approach. With regards to positioning, it all depends on surgical approach. So retroperitoneal approach, the patient's in a lateral decubitus position with flank extension, obviously the surgical side up. Some of the benefits of this positioning, it avoids, this approach, the surgical approach, is that it avoids the peritoneal cavity. So it's less complicated if prior abdominal surgery, you don't have to go through those adhesions. But there are some risks associated with this approach as well, including difficult access to the inferior vena cava if the cancerous lesion were to invade that vessel. Increased risk for pneumothorax and decreased vital capacity by about 20% because the patient's in a lateral position with extension of their downside flank, if you will. The second approach is obviously anterior, so the patient is placed supine. This increases the risk of visceral injury and peritonitis because it's the surgeon obviously has to tunnel through the peritoneal cavity to get to the posterior located kidneys. But it does improve access to the renal pedicle and again access to the inferior vena cava if that were involved in one of the cancerous lesions. And just a side note, right atrial catheters, just note they're absolutely contraindicated if the renal lesion extends up high into the IVC or into the right atrium itself. If a central venous catheter is indicated, it should be placed ipsilaterally to the procedure side. And this is simply because CVC placement and nephrectomy both carry a risk of pneumothorax, and you definitely do not want to take that risk on both sides of the patient. So you take that risk on one side and potentially have unilateral pneumothorax versus bilateral. So with regards to intraoperative considerations, so choice of anesthetic, and again, this is all going to be based on your patient's comorbidities, which can be quite extensive with regards to this patient population, why they're coming in. But just know that infection, bony metastasis, or coagulopathy may preclude neuraxial procedures. Continuous lumbar epidural decreases the stress response of surgery and improves post-op ventilation, reduces duration of ileus, so those are some benefits of using a neuraxial technique for this procedure. But the procedure will require additional hypnosis, paralysis, and blunting of hemodynamic responses to DL, so it's not like you can potentially do this under sole neuraxial technique. You still have to have some anesthesia, intravenous anesthesia to supplement the patient's surgical experience. And then intra and post-op analgesia, again, systemic opioids or neuraxial technique, depending on, again, your patient's medical history. With regards to risk management, so the major risks, like we've already kind of talked about of this procedure, are hemorrhage. So you want to make sure you have adequate IV access. You want to ensure that the patient is type and crossed and that units are available, fairly quickly, because the book says if these patients bleed, they bleed quick, or they bleed extensively. So it may not be a bad idea to have a couple of bottles of albumin in the room, just to kind of get you through that short period of time where you're waiting for blood to arrive. And then also you may consider having a rapid infuser, a hotline, or a level 1 infuser already loaded up and ready to go with your blood transfusion Y2B. And then just be mindful of diaphragmatic injury or pneumothorax. Those are things that may necessitate a pause in the procedure in order to either repair a rent in the diaphragm, or possibly perform a needle decompression for pneumothorax. So it's those are things to keep in the back of your mind when you work down your differential with regards to the patient ventilating and oxygenating themselves during the procedure. So I pulled up this article regarding upper urinary tract retroperitoneoscopic surgery under epidural anesthesia, and I had said before that you can't do these procedures under just straight neuraxial, and I'd be curious to see how many of you guys kind of caught that, because in fact there was a study here in Scandinavian Journal of Urology, as a matter of fact it's dated this month, April of 2015. So these authors, following the suit of laparoscopic cholecystectomy, herniorrhaphy, and gynecologic procedures under epidural anesthesia, they studied the effects of epidural anesthesia for retroperitoneal laparoscopic procedures, including 15 nephrectomies, which is obviously the subject of this presentation, and then 31 other laparoscopic procedures. But the inclusion criteria were ASA 1 and 2 patients with a BMI under 25 diagnosed with benign upper urinary tract pathology, no history of previous flank surgery. So 46 patients participated with a mean age of 35 years old. 6 of the patients experienced hypotension. 16 of them complained of shoulder pain, which is more related to the laparoscopy than the anesthesia. But the mean procedure time was about 90 minutes. No post-op analgesia was required. All the patients were able to ambulate 4 hours post-operative, and the average hospital stay was 6.5 hours. So the major limitation of this study, though, was the fact that, like I've said through this entire presentation, your anesthetic approach is based entirely on the comorbidities that this patient presents with. And so, as you can see, or you heard me say, these patients were healthy. And so the study calls for additional studies of patient populations with cardiopulmonary and other systemic comorbidities in order to see if this is if neuraxial anesthesia is possible to reduce some of the risks associated with the nephrectomies for those patient populations. So intraoperative considerations, I wanted to just talk a little bit about special considerations for donor nephrectomy. So these are patients that are donating their kidney. So the book mentions low-level anticoagulation, so 3,000 units of heparin, and then a forced diuresis with 12.5 grams of mannitol or 40 milligrams of furosemide, and then post-harvest heparin reversal, obviously. So protamine sulfate, just remember that 1 milligram reverses 90 units of heparin with a max dose of 50 milligrams per dose. That's something that I can close my eyes and envision a test question with regards to that at some point, not necessarily this test coming up. So post-operative considerations with regards to nephrectomy. So remember, you're taking at least partial functionality of the patient's renal system away from them. That's in a nutshell what nephrectomy is. Granted, that kidney may not have worked very well in the first place, but some of them do, and especially in donor situations. You're cutting the patient's functional units in half, so they have 50% loss of neurons. But the book says that just like everything else in the body, that one kidney that's left over somehow accommodates, and you only lose about 25% of actual functionality if you're taking out working neurons on the operative side. You want to manage complications. So again, you've heard this several times now: hemorrhage, potential visceral injury, atelectasis, ileus, wound infection, renal failure, incisional hernia, and then big things like MI, CHF. I think that's PE, not EP. So pulmonary embolism, cerebrovascular accident, and then pneumonia and thrombophlebitis, or some other things that you just want to be mindful of in your post-op management of these patients, or if you get called, these are things that kind of need to be on your radar. And then post-operative analgesia, again, I think we already talked about this, but Neuraxil, if you do decide to use systemic opioids, remember you're not only reducing doses of drugs, but you want to stay away from drugs that have, that are specific to renal metabolism or renal excretion, and those include morphine and meperidine, which have active metabolites that are significantly accumulated with renal dysfunction. And that's the end of the presentation. If you have any questions, feel free to jump on my discussion board and shoot me a question. I'd be glad to delve into this subject a little more and try to get you an answer. These are my references. Thank you guys for your attention. I hope everyone's having as good a time as I am, and look forward to seeing you guys real soon.